ఇందాక ఆఫ్ చేశాను. Good evening, students. Welcome to you all to my lecture from Sri Rama Hospital, Jagaipet. I have seen in the chart some of you are inquiring about the personal things here. So please don't indulge in that. So personal means it is their personal. Don't bother about their colleges. Don't bother about their level of education, etc. Here, everyone is a student. If you have any problem regarding the class or regarding the technical problems regarding these classes, you can put the chart here. So don't indulge in personal comments or personal inquiries. That will keep up the decorum of the class, and we will have a cordial relationship between all of us. I hope I didn't hurt any one of you. Thank you. Yes. Greetings to you all from Sri Rama Hospital. Today's class is on acute pancreatitis. This is one of the most important topics needed for even undergraduates and postgraduate students of surgery, as well as medical students, that is internal medicine students, because though it is discussed at length in surgical classes, most of the management and many of the patients with acute pancreatitis are managed by medical management, that is non-surgical management. But why a surgeon is bothered about this when 90% of the patients are being managed by medical means? Why should we know about it? Because even those 90% of the patients at any part of their period in their hospital may require surgical intervention. That is why these patients, they are mostly managed in surgical wards under the care of the surgeon. Of course, the gastroenterologist or a medical colleague definitely will help in managing these severe cases. Okay, now let us discuss about this pathophysiology of acute pancreatitis, and if time permits, let us discuss about the investigations and management also. As it is routine for us, first let us begin our discussion with anatomy of the pancreas. When you take away the anterior abdominal wall, this is what you see. These are the ribs. This is the costal margin. Here is the episternum, and this is the sternum. And this is what you are seeing here is the peritoneal covering. Through the peritoneal covering, you are able to see the internal abdominal organs. Here you see only the part of the liver in the epigastric region. So much of the liver is hidden under the right thoracic cavity. The spleen also is not seen. You are able to see the lungs, the pleura, and their extent, and this is the diaphragm. The diaphragm muscle intervenes between the costal margin and the abdominal organs, abdominal viscera. Now let us take away the peritoneum and see what is there inside. So this is chest wall is removed now. Now you can see the whole of the abdominal cavity in upper part. Here is the cupola of the diaphragm, and this is the liver, and in the middle is the falciform ligament of the liver. The parietal peritoneum is removed now. Now we can see the stomach. This is the lesser momentum of the stomach, and from the greater curvature stomach hangs the greater momentum. And here is the liver, and in the left corner is the spleen. And gallbladder fundus you are able to see here, projecting from the undersurface of the liver. And this is the transverse colon. The transverse colon is mostly covered by greater momentum here, because the greater momentum arises from the greater curvature of the stomach, so it hangs over the front of the transverse colon. So you are seeing only part of the transverse colon here. Now when you take away the greater momentum, you can see the whole of the transverse colon. The stomach is now taken away. So once you take away the stomach, you can see the peritoneum. Actually, abdominal cavity peritoneum is not a peritoneum that is there all around. It is there all around, but within it there is another sac again. So all around, that means from the anterior abdominal wall to posterior abdominal wall, the lining is called the general peritoneal sac or greater peritoneal sac. In the greater peritoneal sac, there is one more sac. There is one more peritoneal cavity. That peritoneal cavity is called as the, what do you call that? That's very good. It's called the lesser sac of peritoneum. So what you are seeing here is the posterior wall of the lesser sac. The anterior wall of the lesser sac is lining the back of the stomach and back of this lesser momentum and back of the liver. And lesser sac extends into the greater momentum also, into the fold of the greater momentum also. So now we have taken away the stomach. So along with the stomach, the anterior wall of the lesser sac also has been taken away. So what you are seeing is the posterior wall of the lesser sac. So this is all the posterior wall of the lesser sac. This is the transverse mesocolon. You can see this is the transverse colon. This is the mesentery of the transverse colon, called the transverse mesocolon. This transverse mesocolon is actually arising from the middle of the pancreas. This is the pancreas what you are seeing. So behind the parietal peritoneum, so behind the posterior layer of the lesser sac peritoneum, you are watching the pancreas. So from the middle of the body of the pancreas, you can see the transverse mesocolon hanging. And from the transverse mesocolon, you are seeing the transverse colon. And here is the C loop of the duodenum. Except the first 2.5 centimeters of the duodenum, whole of the duodenum is behind the peritoneum. So that is behind the peritoneum. That means duodenum is mostly a retroperitoneal structure. Now we will take away the colon also, so as to see how the pancreas looks and what are the structures adjacent to that one. Now this is the coronal section of the abdomen. You can see here the liver, and this is the lesser sac. Here is the stomach. This is the lesser momentum. And from the stomach, greater curvature, greater momentum is there. So greater momentum comes like this, it turns around and again fixes to the inferior border of the transverse colon. So this is the lesser sac of peritoneum. When you are studying about the pancreas means, you should know everything about lesser sac. The whole anatomy of the lesser sac you should know. That's why I'm showing in detail about this lesser sac. So this lesser sac posterior wall covers the posterior abdominal wall. You can see in this image also, covers the posterior abdominal wall, that means over the aorta, inferior vena cava and lateral sides, and then it covers the anterior part of the upper part of the pancreas. Then it comes as the transverse mesocolon. Then it comes as the posterior layer of the greater momentum. So this is all the lesser sac. So what you are seeing here, the posterior part of the lesser sac. That means if you take away all this stomach and that, so what you are left behind, that you are seeing here. So once you take away the posterior layer of the lesser sac also, then you can see the pancreas. So this is the pancreas. And here is the, so everything what I am talking is the visceral peritoneum. This is all, lesser sac also is visceral peritoneum. It is not parietal peritoneum. Parietal peritoneum is that part of the peritoneum which lines the abdominal wall, either anterior or posterior abdominal wall. Okay, this is the you can see here, this is the lesser side, and you see one line here. This line represents the posterior parietal peritoneum. The posterior parietal peritoneum comes like this. It invests the lower surface of the or the inferior surface of the pancreas, and again it forms the posterior layer of the transverse mesocolon, and it comes like this as the greater momentum. So up to here is the parietal peritoneum on the posterior abdominal wall. This is the again parietal peritoneum on the posterior abdominal wall. So the pancreas head is enclosed in the C loop of duodenum. When you cut the pancreas, you can see the duct inside the pancreas. This is the main duct of the pancreas. This is called the accessory duct of the pancreas. And you can see also the terminal part of the common bile duct. The bile duct coming from the liver and gallbladder, there is common bile duct, joins the main pancreatic duct. And the joint combined part empties into the second part of the duodenum on its medial border over the duodenal papilla. This is posterior to the pancreas. Once you take care of the pancreas, you can see the inferior vena cava, the aorta, the plexus of sympathetic plexus of nerves. This is the called the splanchnic plexus. Splanchnic plexus is a greater splanchnic plexus, lesser splanchnic plexus, and least splanchnic plexus. So there are three plexuses here. So this plexus contains branches from the vagus nerve as well as branches from the sympathetic ganglia. This plexus is the one which distributes the autonomic nerves to whole of the gastrointestinal tract. So this is in the close vicinity of the pancreas. So many of the pancreatic lesions, they can influence this particular plexus and may produce pain or other complications. And this is the kidney on either side. So they are also posterior relationship to the pancreas. In acute pancreatitis, because these are all the immediate organs, so the organs which are there in the immediate vicinity, they also show the reflex or compensatory edema. That means because they are side by side, there will be contiguous inflammatory spread, and they also become edematous. So the anatomy of the pancreas is, the pancreas is longitudinally placed across the abdominal wall. Sorry, horizontally placed across the abdominal wall at the level of L1 vertebra. It crosses from the right side of the abdomen to the left side of the abdomen to the left hypochondric region. It has three parts. The part that is enclosed in the C loop of duodenum is called the head of the pancreas. You can see here superior mesenteric vessels. So they come from the aorta. Aorta will be somewhere here. So from the aorta, the superior mesenteric vessels arise. So all these things are there behind the pancreas. And superior mesenteric vessels which has arise from the pancreas, arise from the aorta, they come behind the pancreas and then they travel in front of this process, the tongue-like process. So this tongue-like process is called as the uncinate process. And that part of the pancreas, which is situated in front of the superior mesenteric artery and vein, is called the neck of the pancreas. Then the remaining part is called the body. Then the leftmost part is called the tail. There are two ducts here. One is the main duct, that is called the duct of Wirsung. The other thing is the duct of Santorni. The main duct is joined by common bile duct, and the conjoint duct or the combined duct traverses through the wall of the duodenum and opens on the duodenum second part over a elevated portion called the papilla of water. This papilla of water is surrounded by, and also the terminal part of the bile duct and terminal part of the pancreatic duct are surrounded by a sphincter called sphincter of Oddi. So one student has asked about celiac axis means. Celiac axis means it is the division of the arteries. Aorta will be like this. From aorta, celiac artery comes like this, just 1 or 2 millimeters. Immediately afterwards, it divides into 3 branches. One branch goes like this. This is the hepatic artery. One branch goes like this. This is the splenic artery. And one branch goes upwards like this. This is the left gastric artery. So 3 branches will be arising from front of the aorta. Sometimes the celiac artery itself, the small twig also will not be there. These 3 branches, they arise from front of the aorta directly. So when they are arising from the front of the aorta, it looks as if 3 rays are coming out from the aorta. So that is why they are called the axis, celiac axis. That means something radiating from the aorta. So celiac axis means it is about the arterial system. Splanchnic plexus means it is plexus of nerves, plexus of autonomic nerves, sympathetic and parasympathetic. The sympathetic nerves in the gut, they are efferent fibers. They carry stimuli from the gut. They carry pain sensation from the gut. Efferent fibers. Efferent fibers means these fibers carry impulses to the gut. That is, they are secretomotor and motor fibers coming from the vagus. They are the efferent fibers. Now let us enlarge here and then just focus here. This is the terminal part of the pancreatic duct. This is the common bile duct. Both of them join. And this is the combined part is having small dilatation. So this dilated part is called the ampulla of water. And this opens into the papilla of water. And this passes obliquely across into the duodenal wall. It is not straight entry. It is an oblique entry. Whenever this oblique entry is there, that will facilitate prevention of reflux mechanism. Reflux of the duodenal contents into the bile duct or the pancreatic duct, they are prevented by this oblique mechanism. You find a similar type of arrangement in some other area. Can you tell me? Similar type of arrangement. Very good. Uretrovesical junction. So ureters, they also have an oblique course through the thing. Wonderful. Another thing is the eustachian tube. Another example is eustachian tube. Very good. This is the papilla, and this is the appearance of the papilla projecting from the duodenal wall. So these are all the rugae in the duodenum, and you can see this papilla. The blood supply, of course, is not relevant for us. It is mainly from the celiac and superior mesenteric arteries. Of course, in the next class, I will tell you about the gut innervation and sensation from the gut, how the pain from the gut is manifesting. So the preliminary features about the abdominal cavity organs, so those I will tell you in the next class. Of course, already I have told you these pictures. This is lesser sac, already I told you. This is there between the stomach and the pancreas. It contains some fluid. And this is also called the gastric bursa. This is also called gastric bursa. Why this lesser sac is there? The functional utility of this lesser sac is it has fluid in that. When the person lies supine after taking a meal, then what happens? The posterior wall of the stomach falls against the vertebral body and it may get injured. That's why God has put some water cushion just behind the stomach. So even when you lie down after taking a full meal with a very big distended stomach, the stomach wall will not go and rub against the vertebral column because of this lesser sac. That is why the earlier surgeons they call this as the bursa of the stomach. Of course, these are the posterior relations. Already we have seen this. So pancreas is situated on the post-abdominal wall in the retroperitoneal space. It is situated behind the lesser sac, over the inferior vena cava and aorta across the abdomen. It is divided into head, neck, body, and tail. The head is situated in the C curve of the duodenum over the body of the second lumbar vertebra. Uncinate process is a tongue-like extension from the head passing behind the superior mesenteric vessels. Behind its neck lies the aorta and superior mesenteric artery and vein. The tail extends up to the hilum of the spleen. The gland is made of exocrine glandular tissue up to 80 to 90%, organized into lobules. And pancreas is having endocrine glands also, organized as clusters distributed throughout the gland as islets of the Langerhans. And of course, they are in the stroma of the pancreas. The exocrine external tissue drains through the main pancreatic duct, that is called duct of Wirsung, and the accessory pancreatic duct, that is called duct of Santorini. Both the ducts open on the medial wall of the second part of the duodenum. The duct of Wirsung opens onto the papilla of Vater after joining the CBD. The duct of Santorini opens on the little proximally placed accessory papilla. Blood supply from celiac artery, from superior mesenteric artery, the venous drainage into superior mesenteric, splenic, and portal veins. Histology, it has exocrine tissue, lobules, ducts, isthmi, interlobular duct, and main ducts. Endocrine tissue, there are many types of endocrine cells in the pancreas. There are the islets of Langerhans called. There are mainly 3 types of cells, but there are many more cells are there, but they are small percentage. B cells, also called the beta cells, they are about 75%, they secrete insulin. A cells, also called alpha cells, they are about 15%, they secrete glucagon. D cells, they about 8%, they secrete somatostatin. These are the main islets. The other things being VIP cells, vasoactive intestinal polypeptide hormone secreting cells. G cells, they secrete castrin. They are mostly situated in the head and neck of the pancreas. G cells are present apart from pancreas. In which other organs or which viscera G cells are present? Stomach means, please specify stomach. Which part of the stomach? Stomach is correct, but it is completely not correct. You specify the part. Fundus, sorry, it is not fundus. It is not body. So the left thing is not cardiac orifice. Yes, it is pylorus. The pylorocantrum has G cells. Still, any other viscera has G cells apart from pylorus or the stomach and pancreas? Apart from pylorus and pancreas, any other viscera, does they have G cells? Very good. Duodenum, which part? First part of the duodenum and second part of the duodenum. Very good. So what do you call that triangle in which the G cells are present? Pesserose triangle. Very good. Also called as the gastronoma triangle. Pesseros gastrinomas triangle. Wonderful. You're right. Physiology, meal in the duodenum. There are two types of meal. One, it is mixed with the acid, that's called the acid chyme. Then other is the protein meal. Whenever the acid touches the duodenal mucosa, secretin is produced. Secretin produces bicarbonate-rich fluid from the pancreas. The patient takes a protein meal, then cholecystokinin and vagal stimulation produces enzyme-rich secretion, that is 6 to 20 grams of protein per day. The enzymes of the pancreas being amylase, trypsinogen, there is a precursor for the trypsin enzyme, which is a powerful proteolytic enzyme. Amylase is an enzyme to digest the carbohydrate. Then lipase, chymotrypsinogen, ribonuclease, elastase, and the hormones being already we discussed: insulin, glucagon, somatostatin, VAP hormone, etc. Now, what will happen to all these enzymes secrete into the intestine? They secrete into the duodenum. Almost 5 to 10 grams of protein is digested. This elastase is for digestion of the elastic tissue of the blood vessels. If a person takes non-vegetarian diet, it may contain some blood vessels, the diet. The elastic tissue that is there in the wall of the blood vessels will be digested by this elastase enzyme. Why are you bothered to know about these enzymes here at all? Because in acute pancreatitis, all these enzymes are released from the pancreatic surface into the retroperitoneal area. Just now we have seen these retroperitoneal structures over which pancreas lies: aorta, its branches, veins, lymphatics, nerves. So all these things are bathed by these enzymes. These are powerful lipolytic, proteolytic, and enzymes which digest the carbohydrates or the starch. So, but in the body, tissues, we have mostly the protein products and fat products. So they are digested. This elastase now digests the blood vessels. So the pancreatic enzymes can seep into the transverse mesocolon. We have seen transverse mesocolon hangs from the anterior surface of the pancreas. So these enzymes can pass into transverse mesocolon. Transverse mesocolon has blood vessels to the transverse colon. So these can be digested and they can cause thrombosis, and that can lead to gangrene of the transverse colon. So gangrene of the transverse colon and hemorrhage into the peritoneal cavity are one of the serious complications of acute pancreatitis. They occur because of this elastase enzyme. So for this reason, we have to know about elastase enzyme. Okay. Of course, their physiological role is to digest the elastic coat of the blood vessels in the non-vegetarian diet. Excellent. Another usage of this elastase is to estimate the exocrine activity of the pancreas by estimating elastase in the fecal matter. If you want to study how much enzymatic status is there, whether enzymes are active or not from the pancreas, or secreting or not, in certain conditions, the pancreatic exocrine failure will be there. So in such condition, you can test for the elastase. If elastase is positive, means the exocrine system of the pancreas is working normally. Okay. So out of this subject, what will happen to these enzymes in the gut afterwards? Tell me. Will they be reused, or will they be excreted in the stools, or something will happen to these enzymes? Excreted, absorbed in proteolvine? No. What are they made of? Enzymes are made of not enterohepatic circulation. Intrahepatic circulation is only for bile salts. Please note it. These enzymes, they are not absorbed in the hepatic circulation. In the intrahepatic circulation, urobilinogen and bile salts are only reabsorbed. Please note that. These enzymes are made of proteins. So what will happen to the proteins? These enzymes digest themselves. So ultimately they become the amino acids. The amino acids will be absorbed into the gut. So the trypsin or lipase or chymotrypsin, they are not absorbed. They are digested. So note this point, because once you become practitioners, some of the medical companies, pharmaceutical companies, they will come to you and they may promote a drug which is made of trypsin, chymotrypsin, as an anti-inflammatory agent, and is one of the highly sold drug in the world, especially in our country. Trypsin and chymotrypsin combination under the label of anti-inflammatory agent, because these enzymes, they will go to the inflamed site and they will digest the protein material there, and that will cause relief of the edema and swelling will come down. That's what they claim. But these enzymes, when taken by mouth, they are not absorbed as such into the bloodstream. They are digested like these MLAs, trypsinogen, lipogen, lipase, chymotrypsinogen, ribonuclease. What is happening to all these things? They are digested to amino acids. The same thing happened to those enzymes also. So that is why don't prescribe such drugs. Whenever you prescribe some drugs, you use your logical thinking. You should not unnecessarily use drugs to our patients, and we should not unnecessarily tax them. So there is no use for those drugs except as placebos. They are not even digestive enzymes because they are not having sufficient concentration to digest the food also. So they are neither useful as an enzyme preparation for digestion of the food, nor useful for control of edema. They are simply digested and few molecules of amino acids are added to the circulation. That's all. So there is no use for that. Use of elastase is for digestion of elastic wall of the blood vessels. That is, when a person takes some animal diet, that is non-vegetarian diet, that may have blood vessels, that will cause it. Its role in acute pancreatitis, I will explain it again in the pathogenesis. In the pathology, I will show it again. Investigations to evaluate pancreatic damage, you have to measure MLAs in the serum. To evaluate pancreatic function, you can do fecal elastase test that is simple and specific. Previously, these tests are done, CCK provocative test and Lundy test were done, but they are not useful nowadays. So nowadays, the exocrine function of the pancreas is judged by this fecal elastase test. To evaluate morphological abnormality of the pancreas, you have to go for imaging studies, that is CT scan, or contrast enhanced CT scan. That is the gold standard for pancreas. So how is this that is becoming so rampantly used for every edema patient we give? So that is the wonder of the pharmaceutical companies. So the thing is, the pharmaceutical companies, they play on your sentiment, they play on your emotion, they do emotional blackmailing with their compliments, with their samples, etc., etc., etc. That is why don't go with them. So from the beginning of your practice, have a principle not to touch a sample and not to touch a compliment from the pharmaceutical companies. Then your pen will think the rational things only, and you will prescribe whatever that is exactly needed to the patient without causing any extra burden on his pocket, an extra burden on his body. So these are all, there are many useless drugs that are being marketed in the country. Not at all useful. They are only to exploit the lay common man through learned professional people like us. So be careful not to fall into the trap of these pharmaceutical companies. If they give some literature, you accept it and you can go through the literature, but don't accept the samples or compliments. Image studies. You should not give these enzymes intravenously. If edema is there for any part of the body due to some inflammation, what is the best form of treatment? Tell me, to relieve the edema. Any inflammatory edema, what is the best solution to relieve it? No, what you have said is wrong. No, the best treatment is very good. Fatima, you are right. It is elevation of the part, rest and elevation of the part. Of course, the steroids and non-steroidal inflammatory drugs also will be helpful. That's all. So the best form of treatment is advise the patient not to move and keep the part elevated. Elevated than the elevation means it is at a higher level than the heart level. That relieves the edema within 6 to 10 hours. However, severe inflammatory edema is there, that will relieve within about 6 to 10 hours. So you go with that, not with the useless drugs. So from now onwards, you stop prescribing those protein drugs or enzyme drugs for relieving edema. So CT scan and spiral CT scan, they are very useful. MRI scan, that is for ductal anatomy and for fluid collection. ERCP for ductal anatomy. So these are the imaging studies. Now let's discuss the proper topic on the acute pancreatitis. Just 1 minute. Okay, I will tell you about those investigations. Just I had made a brief review of overview of the tests what we do for a pancreatic disease. But in acute pancreatitis, what tests we do and all that, I will just tell now. Okay, pancreatitis means what? Inflammation of the pancreas. Now again, I will ask you about define inflammation. Define inflammation. Already we have discussed it in the previous class. Just to check how much you have absorbed it. Wonderful. Protective response of the body to sublethal irritation. So that means inflammation means it is not only due to infection. Oh, Damri, you made infection there. Not only due to infection, it can be due to any irritation. The irritation can be physical agent, chemical agent, biological agent. Biological agent means this is infection. Physical and chemical agents, they can also cause irritation to the tissues and can provoke the inflammatory reaction. So this pancreatitis is inflammatory condition of the pancreas. And this inflammatory condition is not because of biological irritation. That means it is not because of infection. It is because of some chemical irritation that is causing the inflammation. So that is why I asked you again to tell about the definition of pancreas or inflammation. It is the inflammatory condition of the pancreas due to autodigestion by activation of intracellular trypsinogen to trypsin. So this is the definition. Of course, I will explain this statement now. Types: acute pancreatitis, chronic pancreatitis. Acute means sudden and severe pancreatitis. Chronic means slow, insidious, and persistent pancreatitis, progressive pancreatitis. Progressive destruction of pancreas leading to irreversible changes. Both are different phases of same disease process. They are not separate. A patient with acute pancreatitis can progress slowly into chronic pancreatitis after resolution of the inflammation. A chronic pancreatitis patient may get now and then acute exacerbations and may manifest with acute pancreatitis. So both these things are interrelated. When our patient presents to you with severe sudden pain, we call that as acute pancreatitis. When it is a continuous pain persisting for about few months or years, we call this chronic pancreatitis. First, let us discuss about the acute pancreatitis. This is today's topic. Incidence: 3% of all acute abdominal conditions occurs at any age, but most commonly it affects the younger individuals. More common in young males and old females. Etiology: alcoholism. This is about 25% of the cases are due to alcoholism. Biliary tract disease is 50 to 70%. So these statistics what I am mentioning are from the Western world, but our Indian statistics they are reverse. Alcoholism about 70% and biliary tract disease around 25 to 30%. Trauma, usually blunt abdominal trauma. Infection by virus like mumps virus. Mumps virus, it infects other glands also. What are they? Parotid arthritis. Very good. Very good. That means it infects all exocrine glands. In simple words, all the glands which have ducts, mumps virus can infect. So it infects salivary glands, it infects pancreas, it infects testes. Very good. Then there are minor or rare causes. There are metabolic disorders like hyperparathyroidism, Scott-Penstein, diabetes mellitus, hyperlipidemia, and collagen disorders like PAN, hereditary, a rare familial condition due to mutation of cationic trypsinogen gene. It progresses to chronic pancreatitis and are at risk of developing carcinoma of pancreas by age of 70 years. So there is a type of hereditary pancreatitis also is present. And postoperative pancreatitis, that means when you do surgery around the stomach, bile ducts, sometimes liver, patients may develop this particular acute pancreatitis. What is the PSSR gene? Okay, SPINK, okay. All these things, they cause only one thing: activation of the precursor of the trypsin to trypsin, that is trypsinogen to trypsin. So what are all mentioned here? The hyperparathyroidism causing hypercalcemia, the hypercalcemia will be causing premature activation of trypsinogen to trypsin. And ERCP also can provoke acute pancreatitis. Certain drugs also can cause acute pancreatitis. Idiopathic pancreatitis, in some cases, the etiology cannot be made out. And these cases are more likely to have microleaks in the biliary tract. In India, alcohol is the major cause of acute pancreatitis, both acute and chronic. The pathophysiology of acute pancreatitis. The main cause for pancreatitis is activation of pancreatic proenzymes in the SNR cells. That is the main cause. Because of this, in the SNR cells, the enzymes are in a inactive state. They come out into the duct, they pass into the duodenum. So in the alkaline duodenal secretions, and when they mix with bile, they are activated. And that activated enzymes will cause digestion of the various foodstuffs. So that's why digestion takes place only in the lumen of the gut. Though these powerful enzymes are there which can digest anything a man eats. So a person can eat the animal and the animal gets digested by these pancreatic enzymes. They are so powerful. So they digest everything. So there was, in earlier days, there was a surgeon by a name called Beaumont. He got a doubt. When these powerful enzymes are there in the body digesting whatever we eat, why they are not able to digest the stomach, the intestines, the pancreas, etc., etc. He got a doubt. So he did a lot of experiments for that. And then he was the one who discovered that they are in the proenzyme state or inactive state, and later they become activated once it comes into the lumen of the guts. Of course, there's a big biographical story about that, how he invented that. And some other day when we discuss about the stomach, then I will tell you about that. The activation of the pancreatic proenzymes in the SNR cells leads to activation of the enzymes. These enzymes now will digest the pancreas. So there is auto-digestion. That means it causes irritation. So whenever something is happening to the cells, cells are injured, cells are damaged or damaging, then there will be inflammatory reaction. So there is acute inflammation. We already seen inflammation means what? What pathological changes will be there in acute inflammation? In the tissues? What are the two main pathological changes that you face in acute inflammation? Anywhere in the body, whenever there is acute inflamed area, what will happen to the tissues? There will be two things. Number one, edema is a sequelae of those two events. What are those two events? Vasodilatation, wonderful. Of course, inflammatory mediators will do that. Vasodilatation, number two, activation of coagulation factors, dilatation of blood. That is vasodilatation. Capillary leak, yes. So the main two things that occur are vasodilatation and fluid exudation. Along with the fluid, there will be passage of the cells, white cells, and other cells, monocytes, into the tissues. So there will be leakage and there is vasodilatation. So in the pancreas also, the vessels are dilated, there will be exudation of fluid. And along with that, there is necrosis and rupture of the SNR cells because of digestion. So they liberate the enzymes into the peripancreatic tissues. So the peripancreatic tissues now have a lot of fluid, lot of enzymes. What the enzymes will do now? The peripancreatic tissues are also now digested by these enzymes, and they are also inflamed. So this is a very vicious process. How this activation takes place if there are gallstones in the gallbladder. One of the stones may come and impact in the ampulla of water. we have seen the terminal common bile duct joins with the main pancreatic duct. They have a common channel. So when the papilla of water is blocked by a stone coming from the gallbladder, then what happens? The bile, which is coming from the liver, cannot pass into the duodenum. It regurgitates. It regurgitates in the pancreatic duct. And from there it goes into the branches and then ductules and into the acini. Now the acini are filled with this bile. Bile contain alkaline juice, lysolecithin, bile salts, beta glucuronidase. So these things will now activate the proenzymes into the active form. So activation of proenzymes is the zymogen granules. This leads to activation of trypsinogen to trypsin, and an enzymatic cascade now develops, and all the other enzymes are also now get activated. The result is edema and vasodilatation of the pancreatic tissue. That is the acute inflammation. So this is acute pancreatitis. So this is how acute pancreatitis occurs. The activators of pancreatic enzymes being gallstones with bile reflux due to common channel. Alcohol. Direct action of alcohol on acinar cells producing protein microplugs in the ducts causing retention. So whenever there is retention and stasis, then there will be reflux of contents into the pancreatic ducts leading to activation. Again, alcohol can cause spasm of the sphincter of the aorta, and the sphincter aortic spasm will be there for a very long period. So the sphincter aortic contraction can lead to reflux of bile into the common channel again. These changes are aggravated by smoking. So usually, an alcoholic patient will have the habit of smoking also. So when both of them are there, the problem is very high. Other possible mechanisms are associated malnutrition, concomitant smoking, hyperlipidemia, genetic predisposition, and hypersecretion. So these are the other associated mechanisms for causing alcoholic pancreatitis. But the exact mechanism is not known. When you see so many things are there, that means these are all, most of them are postulates. Some of them are still under process of evaluation. So the exact cause is not known. These are all the possible things that were thought of. Trauma, by direct trauma, blunt trauma, the release of enzymes for the injured ducts and injured acini can lead to acute pancreatitis. Hereditary pancreatitis, abnormality in chromosome 7 allowing intracellular activation of enzymes. So whenever there are activators like alcohol, gallstone blocking the common bile duct, then what will happen? There will be disruption of cell membrane by the lysolecithin and oxidation of tissues by proteases and lipase, and blood vessels by elastase. I told you already, the elastases, because it has the enzyme to digest the elastic tissue. The vasomedia of the blood vessels have the elastic tissue. So this elastic tissue is digested by this elastase enzyme. This leads to inflammatory process of the pancreas. If the inflammation becomes severe, there will be necrosis of the pancreas and surroundings. Surroundings means greater momentum, retroperitoneum. You find the fat getting necrosed by the lipase. The stages of pancreatic inflammation: edema, hemorrhage, necrosis, infected necrosis. So these are the 4 stages. First, it will be edema. If inflammation is severe, it progresses to the other 3 steps. Infected necrosis is the severest form of acute pancreatitis. So it carries very high mortality, and patients need very high intensive treatment. This infected necrosis due to secondary infection The sterile necrotic pancreas is infected by gas-producing and gram-negative organisms by this translocation from the gut. What do you understand by translocation? I mentioned here the word translocation. So tell me, what do you understand by translocation? Moving from one location to the other location. Example, you know the commensals in the gut. What are the commensals in the gut? The commensals, there are many gram-negative rods, gram-negative cocci, and anaerobic organisms. That means E. coli, protease, bacteriads, and many Pseudomonas piscineus, and so many other bacilli are there in the gut. So all of us are carrying those bacilli in our intestines. But we don't suffer from the infection because our gut and those bacteria live in harmony. These are just like the street dogs. The dogs wandering in the street. What they do, they survive by the food that is thrown from the houses that are there in that particular street. The waste what we throw it in the street, so they eat them and they survive. And in the night when some thief or some unknown person comes into the street, they bark. They bark till that fellow goes away. So these bacteria also do the same thing. They eat on the undigested material that is there in the intestines, terminal ileum and colon, whatever that is being left behind, so they live on that particular material. And they protect the gut from invading other organisms. If any other organisms come there, so they will protect the gut from those organisms. And they produce a lot of useful vitamins to the body. They have many other useful things also are there. But these commensals, if you take them from the terminal ileum and put them in the ureter, put them in the kidney, put them in the bile duct or gallbladder, put them in the pancreas, what will happen? The location has changed. That is called translocation. So these are commensals only in the gut. If the environment is changed, they become pathogenic. Pathogenic means they multiply, they invade, they go into the lymph, they go into the blood vessels, they cause sepsemia and other serious problems due to spreading infection in the body. So these microbes which are there, as long as they are there in the gut, they are harmless. But they become harmful when their location is changed. That is number one. Number two, when motility of the gut is changed. Number three, when perfusion of the gut is changed. When the gut wall has become less perfused, then these microbes, they pass into the gut, they go into the bloodstream and they spread all over the blood. So one of the factors for multiple organ dysfunction syndrome in case of untreated or lately treated hypovolemic shock, we have discussed in 2 days before, is this translocation from the gut. When the microbes go from the gut into the circulation, they cause pathological effects like sepsemia and systemic inflammatory response syndrome, that is SIDS. So this is one of the factors responsible for MODS. There is multiple organ dysfunction syndrome in any case of peripheral circulatory failure. So now these get translocated from the gut into the pancreas, because whenever there is acute inflammatory reaction in the pancreas, then what happens? There will be reflex paralytic ileus of the gut. We have just now seen the pancreas is lying over the aorta. The aorta is covered by all splanchnic plexus. So the splanchnic plexus is bathed by these chemical agents released from the digestion of the pancreas and surrounding tissues. So they get irritated. So whenever a nerve is irritated, it stops functioning. When it stops functioning, say this pancreatic system is not functioning, means the gut becomes paralytic. That is called paralytic ileus. So acute pancreatitis is usually, in most of the cases, is associated with paralytic ileus. So when paralytic ileus is there, there is motility of the gut is reduced. There is accumulation of fluid inside the gut. So whenever motility is affected, just now I told you, so these bacteria will become pathogenic. So they go into the gut wall and they go across the gut wall into the peritoneal cavity and they go into the pancreas. Like that, this necrosis in the pancreas will be infected by the translocation of the bacteria coming from the gut. The gut bacteria, they are anaerobic organisms are there, which are gas producing. Gram-negative organisms are there, which produce severe sepsemia. Once it happens, it spreads in the retroperitoneum and go into the mediastinum, causing major source of severe sepsis and sepsemia, which aggravates organ failure. The mortality is 20 to 40% in these cases. So the progression of pancreatic inflammation is starting as edema. If the inflammation becomes severe, there will be hemorrhages because of digestion of the blood vessels. And if the inflammation is very severe, there will be necrosis. Anywhere in the body, same things will happen in inflammation. And this necrotic part may get superadded infection by the organs coming from the gut. So this becomes infected necrosis. Once infected necrosis is there, there is now twofold type inflammation. One is due to chemical reagent, there is inflammation. Second is due to bacterial infection, there will be inflammation. So bacterial infection is always superior in causing pathological damage to the body. So the bacterial agents, they spread by bloodstream and lymph stream and they cause sepsemia and systemic inflammatory reaction. The necrosis pancreas produces the following. It causes fat necrosis. It causes isthmus cells are damaged. From the damaged isthmus cells, the pancreatic enzymes seep into the peripancreatic tissues. There will be systemic absorption of these enzymes into the bloodstream also. Fat necrosis, it is due to saponification of tissue fats by lipase. So the lipase which is liberated from the pancreatic isthmus cells, they digest the lipase, they digest the fat, the adipose tissue. Fats are first converted to glycerol and fatty acids. The fatty acids combine with calcium that is there in the tissue fluid and plasma and forms the calcium stearate and calcium oleate. That is, they form soap-like material in the tissues. This is called the fat necrosis. So sometimes you get a short notes question on fat necrosis. So fat necrosis is nothing but formation of soaps in the tissues. The soaps are nothing but combination of fatty acids with calcium. There is calcium stearate and calcium palmitate. These fat necrosis are seen in the vicinity of the pancreas, greater momentum, over the peritoneal surfaces, pleura or pericardium. And sometimes in the subsynovial fat of the knee joint also you can see these things. Because of the lipase which is absorbed in the blood circulation will travel all around the body and can cause necrosis of the fat at any place in the body. These fat necrotic areas are dull, opaque, yellowish white, resembling bubbles of wax. They just look like wax. Fat necrosis leads to hypocalcemia. So if there is severe fatty necrosis, lot of calcium in the body will be consumed in the formation of these soaps. So that leads to hypocalcemia. So estimation of calcium is one of the markers for assessing the severity of the pancreatitis. Now, when the pancreatic isthmus cells are damaged, what will happen? Let's see. This is inflamed pancreas. They're very much swollen. There is necrosis of the pancreatic tissue. So there is liberation of enzymes in the peripancreatic tissues along with inflammatory fluid. Now these exudates, they pass along the aorta and inferior vena cava through the hiatus for the inferior vena cava, through the opening for the aorta into the thoracic cavity, into the mediastinum. Once they go into the mediastinum, they cause irritation of the lung tissue, and lungs and pleura are irritated and they secrete a lot of fluid. So whenever the lungs alveoli are edematous, that results in the condition called the ARDS, adult respiratory distress syndrome, and mediastinitis. And these enzymes, they seep all around the pancreas in the retroperitoneum. So the retroperitoneum is now flooded with pancreatic secretions, and they go to the flanks and accumulate there. They cause digestion of tissues there, and they cause rupture of the blood vessels, producing hemorrhages in the flanks. That means they produce hemorrhages in the retroperitoneum also, but they are seen in the flank regions. So seepage of pancreatic enzymes into the retroperitoneum and mediastinum, producing mediastinitis and ARDS. Into the flanks, producing subcutaneous hemorrhages in the flanks. And these enzymes, some of them are absorbed into the bloodstream. So this is what happens if you inject the proteases into the blood. So in the beginning of the class, one of your colleagues have asked me, can you give intravenous injection of these enzymes, trypsin, to cure edema of the inflammation? So this is what happens if you inject the enzymes into the circulatory system. There will be secondary activation of complement, kinins, fibrinolytic protease enzymes with stimulation of inflammatory mediators and free oxygen radicals. This leads to systemic inflammatory response syndrome. This leads to multiple organ dysfunction syndrome. Complications are sequelae of acute pancreatitis. General complications, just now we have seen there will be systemic absorption of these enzymes into the bloodstream, which will cause systemic inflammatory response, which can lead to multiple organ dysfunction. So that is why there can be generalized complications and local complications. General complications, this is called the multiple organ dysfunction syndrome. In the earlier days, it was called as the multiple system organ failure. The complications being cardiovascular, in the form of shock, arrhythmias, pulmonary complications, in the form of ARDS, that is respiratory distress, kidneys, renal failure, hematological, it can produce disseminated intravascular coagulation, metabolic, they produce hypocalcemia, hyperglycemia, hyperlipidemia, gastrointestinal paralytic ileus, neurological irritability and encephalopathy. So these are the complications we face due to acute pancreatitis. So all these complications doesn't occur in every patient. The disseminated intravascular coagulation occurs because of activation of the coagulation factors by the enzymes. They cause activated thromboplastin, then prothrombin, then fibrin gets clotted. Fibrinogen gets clotted into fibrin, and then there will be intravascular thrombi disseminated. Local complication being pseudocyst, abscess, ascites. Summary of the pathology. Exactly, I don't know how hyperlipidemia occurs. Probably they are increased because of the rupture of the adipose cells. So when adipose cells are digested, then there will liberation of, when cells are digested, the cells contain a lot of triglycerides in them. So when the cell is broken because of the lipase action, so the cells are broken, the fat that is there in the cells will be liberated out, and that fat is nothing but triglycerides. So that's why there will be increased triglycerides in the bloodstream. So probably that is the reason. Exactly, I don't know. This is only my surmise. That means I thought of like that. So please check and then tell me whether it is correct or wrong. Summary of the pathology: the gallstones, alcohol, other miscellaneous agents, they activate proenzymes in the pancreas. This leads to autodigestion of the pancreas, that is acute pancreatitis. These are the phases in which the acute pancreatitis goes: edema, hemorrhage, necrosis, infected necrosis, leading to abscess. So these are the 4 stages. If the necrosis is there, there will be peripancreatic seepage and digestion of the peripancreatic tissues. Because of this peripancreatic digestion and irritation, it will produce respiratory distress, fat necrosis, ascites, and pseudocyst. Pseudocyst is nothing but collection of fluid around the pancreas, which is walled, which is fibrous. There is systemic absorption of enzymes and inflammatory mediators. This leads to systemic inflammatory response syndrome, leading to MOTS. So ultimately, these 3 things happen: inflammatory changes in the pancreas, peripancreatic digestion, systemic absorption of enzymes. So these 3 are responsible for all the events that you see in acute pancreatitis. So now this is about pathophysiology. Because we have some more time, I will discuss about the clinical features also. Clinical features. Due to local features, patient will have some symptoms and signs. Due to peripancreatic digestion, patients will have some symptoms and signs. Due to systemic absorption and MOTS, patient will have symptoms. That means we can classify or group the clinical features into 3 groups. Clinical features due to local condition of the pancreas, clinical features due to peripancreatic digestion, and clinical features due to multiple organ dysfunction syndrome. Due to pancreatic inflammation, pain, which is severe, sudden, excruciating in the upper abdomen, refer to the back, or right or left hypochondria, or to the chest, because the pancreas is situated whole across the abdomen. That is why the pain can be there in the usually the epigastric region, but because it's there mostly in the retroperitoneum, the patient feels pain in the back also, right or left hypochondric regions, and sometimes the pain may even radiate to the chest, because along the aorta and inferior vena cava, these enzymes are inflammatory exudates. They flood the retroperitoneum and they go along the great vessels into the mediastinum, and they produce inflammatory action in the mediastinum, producing severe pain in the chest also. There is many times these pancreatitis patients have to be differentiated from the myocardial infarction and vice versa. Pain relieved by stooping, this is one of the features of pancreatitis, but in acute pancreatitis, this is not observed. Because pain is so severe, the patient doesn't find any posture to give relief from pain. Pain described as illimitable agony. This is Lord Moynihan's statement. Whenever the patient complains that I am not able to have any limit for this pain, so much severe pain is there, then it should be considered as acute pancreatitis. So it is described as illimitable agony. The pain is disproportionate to the signs. So when that patient comes to you, you expect that the abdomen will be completely having guarding. But when you ask the patient to lie down and then examine the abdomen, you don't find any guarding. It will be soft. Mild tenderness, not so much tenderness, because pancreas is situated deep in the post-abdominal wall. That's why if you press from the anter-abdominal wall, the patient may feel only slight tenderness. So pain is disproportionately higher compared to the signs the patient exhibits. There is nausea, vomiting, and retching. Guarding is of course stiffness. So in the next class, I will explain to you all those things, the abdominal symptoms and abdominal signs, how to interpret and how to correlate to make a diagnosis. So that is the first topic I am going to tell you. Once you understand that topic, then the rest of the abdominal topics will be very easy. So that's why don't miss for the first topic. Nausea, vomiting, and retching. Nausea and vomiting, they are because of associated gastric paresis. Because stomach is in front of the pancreas, so whenever the pancreas is inflamed, the stomach goes into reflex paresis. That is called atonic stomach. So atonic stomach, there is no peristalsis, so the patient gets nausea and vomiting. Due to diaphragmatic retching, the patient get diaphragmatic irritation, patient get retching. So this is the distribution of pain in acute pancreatitis. We have seen the seepage of enzymes will be there in the flanks. It collects in the flanks, and you can see there is hemorrhages in the flanks, and there is hemorrhage in the umbilicus. These are described as the Cullen sign and Great Turner sign. Features due to peripancreatic digestion, bluish discoloration of the umbilicus and flanks due to retroperitoneal hemorrhages. Sudden shock or anuria with or without pain. Hiccups due to stimulation of diaphragm or due to gastric dilatation. Abdominal distension due to ileus or rarely due to ascites. There may be mild ictus because of the edema of the head of the pancreas producing pressure over the common bile duct. There may be mild rigidity of the upper abdomen. Pleural effusion is there in 10 to 20% of the cases because of irritation of the pleura by the exudates of the pancreatitis. Due to systemic absorption of the enzymes, there will be shock. The shock can be due to hypovolemia. This hypovolemia is due to fluid loss due to the retroperitoneum and peritoneal cavity, producing third space loss. Neurogenic shock due to severe pain that is produced. The shock can be due to systemic inflammatory response syndrome and due to sepsemia if it is an infected necrosis. So these things will cause the shock in the patient with acute pancreatitis. In the initial few hours, it is due to neurogenic shock. In the first 2 days, it is because of hypovolemic shock due to third space loss. Then after second day, it is due to SIDS. After first week, it is due to sepsemia. Pulmonary complications, ARDS due to SIDS and associated mediastinitis. That means patients will have tachypnea of about 30 to 40 times per minute respiratory rate, peripheral cyanosis, and partial pressure of oxygen tension in the arterial blood is less than 60 millimeters of mercury. There may be renal failure, low calcium, magnesium, and albumin. There may be features of disseminated intravascular coagulation. What is the clinical manifestation of disseminated intravascular coagulation? Why bleeding? Why there is bleeding or petechial hemorrhages? Why is there bleeding or petechial hemorrhages in DIC? Low platelets, very good. Why there are low platelets? They are decreased. Why? Because of usage of coagulation factors. Yes, use the word as consumption. The coagulation factors and platelets, they are consumed in disseminated intravascular coagulation. So because of their consumption, there is thrombocytopenia and other coagulation factors. So this is called as the consumptive coagulopathy. Good, Santi. There are neurological manifestations like irritability, confusion, and localizing signs. The gastrointestinal features as severe paralysis with fluid sequestration, aggravating the hypovolemia. So the appearance of the patient may be normal general appearance with normal vital signs and pain in the abdomen, as in case of mild acute pancreatitis, or gravely ill patient with profound shock, toxicity, and confusion in severe cases. So it depends upon the severity, the clinical presentation. So a revised 2013 Atlanta classification stratifies acute pancreatitis as mild, no local or systemic complications. Local complications, I told you. What are they? Local complications: pseudocyst, abscess formation, ascites, pleural effusion. Systemic complications: what are systemic complications? Multiple organ failures or shock or DIC. So whenever they are there, it is called systemic complication. So if there are no local or systemic complications or no organ failure, we call this mild. Moderately severe: transient organ failure, wherein organ failure results in 48 hours. Patient may have ARDS. You give treatment, within 48 hours, the patient recovers. Then it's called the moderately severe group. Severe pancreatitis: single or multiple persistent organ failure. So one organ or multiple organs are failed for more than 48 hours. Then we call it as severe pancreatitis. So please remember, this is Atlanta classification, and many of the textbooks or many of the surgeons now they follow this classification: mild, moderate to severe, and severe pancreatitis. So this all depends upon the organ failure. No organ failure, mild; organ failure plus but recovered in 48 hours, this is moderate to severe; persistent for more than 48 hours, organ failure, to severe pancreatitis. Why? This is to plan the treatment as well as for prognosis. Most forms of acute pancreatitis are mild. 80 to 85% of cases, fortunately they are mild. They are self-limiting, resolving completely within 3 to 5 days. So because of this factor, we are seeing so many alcoholics. They come to the hospital, they stay in the hospital for 1 or 2 days. Once the pain goes away, they leave the hospital, and again after a month or two, they come back again with acute pancreatitis. Because it is resolving, so they are confident that nothing will happen. If you go there and you have some treatment, so they will be cured. About 15 to 20% of the cases present as severe disease associated with organ failure or local complications. Acute pancreatitis mild resolves that occurs in 80 to 85% of the cases. In the first week, the remaining things, there will pancreatic inflammation, cysts and MARS. This can occur in first week. If patient rallies around the problems during second to third weeks, the patient will have these problems. He may go into infected necrosis, septicemia, or aggravation of MARS. During fourth to sixth weeks, the patient will develop pseudocysts and abscess. This is how the disease progresses. Differential diagnosis, all causes of acute abdomen you have to consider, and also you have to consider myocardial infarction, basal pleurisy, and pneumonia. So these are about the pathophysiology and clinical manifestations of the acute pancreatitis. I hope it is clear to you. If you have any doubts, I will clear it and then go forward to the investigations. Even after MARS, can the patient survive? Definitely. The patients who develop MARS will survive by 60 to 80%. Earlier it was called as organ failure. So the word looks as if they are failed. That means they are irreversible failure. But with our intensive care management, we are able to revive these patients. That is why now it is the new word for this is called the organ dysfunction syndrome. You want dysfunction, not failure. The organs are not functioning, or they are functioning to a lesser extent, or their function is modified. So, depending upon the organ that is dysfunctional, you first monitor it, you identify it before the symptoms manifest, and you manage it. So that all that we discuss in the management. On organ support, is it maybe organ support or whatever it is. Ultimately, it is the support for the patient. Okay, before I proceed to the investigations, just I will briefly tell about the acute pancreatitis summary, what we have discussed so far. It is due to autodigestion of the pancreas by activated pancreatic enzymes, trypsin and lipase. The activators are trauma to the pancreas, bile reflux due to pancreatic ducts due to gallstone in the ampulla of the bladder, that's called common channel theory, or due to alcohol. 80% of pancreatitis are due to alcohol or gallstones. Rare causes are due to the other things. Due to autodigestion of pancreas, edema, hemorrhage, necrosis, and later superad infection causing infected necrosis occur in the pancreas. Again, there will seepage of pancreatic enzymes causing mediastinitis, retroperitoneal hemorrhages, ARDS, and systemic absorption leading to MARS. The local complications pseudocyst, abscess, and ascites. The general complications are due to multiple organ system and organ dysfunction. The clinical features are due to local changes in the pancreas and also due to peripancreatic seepage and due to systemic reabsorption, systemic absorption of the enzymes. This is the investigations. So someone has asked me to show the week-wise progression. So I will show you that. Acute pancreatitis, 85% of the cases, they are mild. They resolve in 2 to 3 days and they go. So mild patients, they will have only 1 week course. The severe patients, during first week, they get pancreatic inflammation and they can manifest with features of MODS. Second to third weeks, infected necrosis, septicemia, aggravation of MOTS. So infected necrosis sets only during second week, not in the first week. This point you must underline and remember, because the indication for surgery in acute pancreatitis is only for infected necrosis. For the edema, hemorrhage, and necrosis, usually you don't intervene. So surgical intervention is there only for the infected necrosis. That means during first week, the severe patient will have MOTS. So your focus will be managing in the intensive care. So first week the patient will be in the intensive care. Second week, if he develops infected necrosis, he undergoes surgery. So then he will be under surgical care. If he resolves, if he is lucky enough to rally around, then during 4th to 6th weeks, the fellow can get pseudocyst and abscess. So this is the progression of a patient with acute pancreatitis, week-wise. So go ahead with the investigations. I will stop here. Actually, I told you that I will tell only about the pathophysiology, but because time permitted, I have gone with these things also. Someone wants to speak out, I will give the mic to him. Actually, I am not observing that mic symbol there. Okay, no one is there. Okay. Just before going to the investigations, I will please give your opinion regarding the paid classes. Now, after you suggested me the topic-wise correction of the fees, I thought that will be better. So topic-wise means so anyway, I will put this one here. Topic-wise means, for example, if I am going to tell you about gallbladder diseases, acute cholecystitis, and chronic cholecystitis, and other gallbladder diseases, and bile duct. So that will be around for 3 classes. So I will put it as if the topic on gallbladder and bile ducts will be there from so and so date to so and so date. The fees will be 300 rupees because it will be around 3 classes. By any chance, if it has become 4 classes, because someone asked some doubts or someplace I have to do more explanation, it will take more time. So if it goes to 4 classes, then no problem. So I will have this 4th class and that will be free. So we are going to charge only for that topic. So shall we have the fees topic wise, then by day wise, or by weekly collection, or monthly? So first topic wise, how many of you favor that? Please tell me. I will announce beforehand. These are the topics I am going to mention. And this many hours will take place. And the fees will be this much. So how many of you favor for this? Okay. Shall I go for the other poll? That is weekly and daily collection. So I'm showing this to all of you. 14 people has voted for yes, and 17 but three people has voted for no. Sorry, 15 has voted for yes and 3 for no. Okay. So there is another thing, daily. So how many of you will say yes and how many of you say no? Let us see. Okay. Actually, reversal of what we have seen in the for the first one. Say someone has suggested weekly collection, weekly payment. Let us see how you respond for that. So most of you have favored for the topic-wise collection. So I will go with you. So first I will announce the topic, how many hours and how much you have to pay. And that also will reduce our technical person's work. Okay. Investigations, they are mainly for two things. So there are some questions on pseudocyst. Pseudocyst itself is another topic. So that is for one whole day it will take place. That means for complete 2 hours it will consume. There I will tell you about completely about pseudocyst. But anyway, I will answer the questions that are given here, are the doubts. Can pseudocyst develop even without acute or chronic pancreatitis? Yes, it can develop following trauma. Sometimes the trauma may be trivial. The patient may not have noticed the trauma. So that can produce pseudocyst. How do we treat pseudocyst? Of course, there are two types of pseudocyst, one is communicating and non-communicating. The non-communicating, they will resolve on its own, or they can be aspirated percutaneously or by transgastrically through endoscope. The communicating type, they require the enteric anastomosis. That means you have anastomosis with the stomach, or C loop of the duodenum, or jejunum, depending upon the nearest viscera that is there and which is adherent to the pseudocyst. Okay, cutoff sign and loop sign, sentinel loop sign, we are going to discuss because we are talking in the investigations. We will talk about the X-ray also. There I will show you these signs also. Colon cutoff sign, how it appears, sentinel loop sign, how it appears, I will show you. Okay, we'll continue with the topic, the investigations. The investigations are mainly to diagnose whether the patient who has come to us with severe pain is having acute pancreatitis or not. So that is number one to diagnose acute pancreatitis. The things needed are you have to go for biochemical investigations, serum amylase and lipase estimation, imaging studies, X-ray abdomen, ultrasound scan, CT scan, MRI scan, ERCP. Then in the case of gallstone and CBD with cholangitis, if you do ultrasound scan, if you find the CBD stone and gallstone, then you can go for ERCP. Sometimes all these investigations will not help you in a case of severe abdominal pain. Then you have to do laparotomy. Why? Can anyone tell me? You have done imaging studies also, biochemical tests also you have done, but you are unable to make out the cause. Patient is having severe pain and showing signs of systemic signs like shock, tachypnea, ARDS, like that. Why? Why do you want to open? It is one to make diagnosis, laparotomy for diagnosis, not for treatment. Necrosis pancreas can be identified on CT scan. That's why you can't miss it on CT scan. Mild pancreas may be missed, but necrosis pancreas can't be missed. No cooperation. No, it's not like that. The thing is, if there is midgut ischemia, that means if the superior mesenteric artery is occluded, arterial occlusion to the gut, then there will be ischemia of the complete midgut. If you operate very early, you can identify it. If you identify it, you can remove the clot or you can do some procedure on the blood vessels and you can restore the blood supply. Otherwise, the patient will get gangrene of the midgut, and you have to remove the whole of the midgut which is gangrenous, and that can lead to very high mortality rate. So that is why you have to do laparotomy if the CT scan doesn't show any findings. Patient condition is deteriorating and patient is having very severe pain. Then laparotomy is justified to see what is there inside. Either you can do laparotomy or laparoscopy. Anything is okay. Then investigations to evaluate the severity of the case, whether it's mild case, moderate to severe, or severe case. That is done by a criteria called Ranson's criteria. Let us see these investigations. So investigations are done with two purposes. Number one, to identify whether it is acute pancreatitis or not. If it is acute pancreatitis, then what is this status? Is it mild, moderate to severe, or severe? Intestinal strangulation in investigations are in differential diagnosis. What is your doubt? I can't get you, Manognya. Tell me again. Investigation will tell about the tests, isn't it? We want to talk about the diseases. But though it is not written here, the laparotomy is done mainly to differentiate from acute pancreatitis from midgut ischemia or any other condition. By laparotomy, nothing will happen to the patient. Even if it is hemorrhagic pancreatitis, nothing will happen. At the most, he may get burst abdomen. If the burst abdomen is there, you can manage it. If the patient has midgut ischemia and you have missed it, then that will cause death of the patient. So if certain serious conditions when you want to treat, when you have to treat, then you have to choose the less serious problem. Both are serious, but out of the serious, which is less serious, that you have to select and do. So whatever that is less damaging to the patient, that you have to choose, but you must explain beforehand to the patient and their attendants. These are the problems that you are going to face by this particular procedure, because his condition is like that. When we do surgery, there are two options. This option will have this problem, this option will have this problem. So I am choosing less problem. So I'm going to do this. So the patient may have certain problems. You have to accept. If you accept that, we will proceed. So you have to explain it, and most probably such serious cases, you must take a video counseling and video consent, not written consent. These days, patients are becoming more intelligent, and lawyers are there exclusively for suing the doctors. That's why we should be more cautious from our side. We must take all precautions. The consent is one of the most important steps we have to take in our practice. Whatever procedure we do, we must take the consent. And in such serious conditions where you expect some mortality, you must always have a video consent. So, because all of us have the video phones in our pockets, so you have the video on and then you record the thing completely. Okay, estimation of serum amylase normally is less than 100 Somogyi units. Nowadays we do it in international units, that is normally is about 100 to 150 international units. In acute pancreatitis, amylase rises in 4 to 6 hours and reaches 4 times above the normal and declines within 4 to 8 days. That means this is rule of 4. Amylase rises in 4 hours, reaches 4 times normal and declines 4 times normal and declines in 4 days. So remember the 4 in relation to the amylase. So after 4 days, if you do amylase, it won't give you any information. For example, normally is about 180 international units. The patient has come to you. He's having around 2000 international units. What is your inference? Is it mild pancreatitis or severe pancreatitis? You are all wrong. You are all wrong. Reason is, amylase tells you whether it's pancreatitis or not. That's all. How much amylase may be raised, it doesn't indicate the severity of the disease. Severity of the disease is not judged by amylase estimation. So please remember that point. So sometimes what happens is we'll see the patients being referred as amylase is 4000 units, very severe pancreatitis. Not like that. It may be 4000 units, that may be just 400 units. It helps in diagnosis, but it has no prognostic value or in any stratification. Elevated amylase is excreted in the urine. So urinary amylase is elevated, and these levels persist for up to 1 week of cessation of rise in the blood levels. It has also false positives in efferent loop obstruction, strangulate obstruction, acute renal failure, biliary peritonitis, like perforated duodenal ulcer, duodenal stump bloat, postoperative biliary leak, perforation of the gallbladder, and parotitis. So because of these, we will go for lipase. Serum lipase estimation is useful to diagnose the condition even if the patient presents later than 4 days. It is more sensitive and more specific. So lipase is better than amylase estimation. Lipase also won't tell the severity. Even mild, very mild cases also you can find the elevated lipase. Serial assessment of C-reactive protein. Serial assessment means you will assess CRP now at the time of admission. Then 6 hours later you do it again. 24 hours you do it again. 48 hours you do it again. So when you do that like that periodically, then you can say if it is progressively increasing, that means the disease also is progressing. It is a useful indicator for progress of the disease. But the disease is increasing or decreasing, that you can evaluate by C-reactive protein. Peak CRP of more than 210 milligrams in the first 4 days predicts severe acute pancreatitis. So this is one of the markers for assessment of the severity. Yes, if there is an associated infection in any other part of the body, CRP will be raised. That's true. There are other indicators to judge the severity. This is not the only one. There are other indicators that I am going to talk now. So the imaging studies. So this is now we are talking about how to make a diagnosis of acute pancreatitis. How to diagnose, how to recognize acute pancreatitis. Plain X-ray abdomen. It is mainly done to exclude perforated peptic ulcer, perforated enteric fever. Bowel loops adjacent to the pancreas may show ileus. Adjacent loops means C loop of the duodenum, the transverse colon. They may become paralytic because they are quite adjacent to the pancreas. So because of the seepage of this fluid and the fluid exudates, they get irritated and they go into paralysis. So C loop is dilated or transverse colon is dilated. When transverse colon is dilated, then you see when you take the X-ray abdomen, you will see only dilated transverse colon. So this is called as the transverse colon cutoff sign. Of course, this is the dilated stomach. The other radiological signs being sentinel loop. So here and there, one or two loops of the bowel you will see because of the paralytic ileus. Renal halo sign. That means around the kidney there will be correction of the fluid, and it gives a halo around the kidneys, both the kidneys. Ultrasound scan, it is less useful. Swollen gland is usually visualized in 25 to 50% of the cases. It helps in demonstrating associated biliary tract disease. Ultrasound scan is less useful. Why? Because whenever you do ultrasound scan, you keep the probe on the anterabdominal wall or on the flanks. So the ultrasonic waves has to pass through the abdominal wall, then through the stomach, then to the pancreas. Then only you can see the echoic structure. When the stomach is filled with air due to gastric ileus or atonic gastric atony, because air will be there occupying the stomach. Air is not a good medium for transmission of the ultrasonic waves. So air it transmits in a bizarre way. The ultrasonic waves are being reflected back. So they are not seen in a proper way. So air is not a good medium. Good medium for passage of ultrasonic waves and visualization of the structures is fluid. Fluid is there, then the ultrasonic waves will pass through freely and you can visualize the organs that are there under the fluid. So because of the ileus, the stomach is dilated, so you cannot visualize the pancreas very well in case of ultrasound scan. Even if there is no gas in the stomach, you can see the edematous pancreas only in 25 to 50% of the cases. The other things like hemorrhage, necrosis, and infected necrosis can't be made out on ultrasound scan. But it is helpful to identify biliary tract disease in the gallbladder stones and bile duct stones can be visualized. CT scan, most useful diagnostic investigation to diagnose disease and its extent. Necrotizing pancreas is seen as decreased pancreas enhancement following IV injection of the contrast. Presence of gas in the pancreas indicates infected necrosis, that is because of anaerobic infection. Involvement of the colon, blood vessels, and adjacent structures can be identified. So this is CT scan. These arrows will mark to this is the inflamed or edematous pancreas, and around the pancreas, the fat is there. That fat has become hyperechoic because of edema. That's called fat stranding. Again, here you can see the edematous pancreas, and fluid is collected all around. The fluid has seeped around the kidneys. You can see the kidney halo sign also here. There is a lot of fluid along with air. When air with fluid is there, you must always suspect that it is infected necrosis, and there is pus. I have told you. Now you can see these two pictures are the same patient. First you do CT scan. Here you are seeing only edematous pancreas. Then what you do is you give intravenous contrast to this patient. After the contrast, you take an X-ray again, scanning again. So contrast medium will go only to the perfused areas. Where there is no perfusion, it won't stain. So here you are seeing the white pancreas. Here you are seeing the black area. The black area means this area is not perfused with the dye. Why is it not perfused? Because it is avascular and necrosed. So pancreatic necrosis can be made out on CT scan by doing a contrast study. So first of all, what you must do? You must do a plain study without contrast. Then you give contrast and then examine again. Once you give contrast, whatever organ that is being perfused with the contrast, it becomes more opaque. You can see kidneys, you can compare this side, this kidney and this kidney. This kidney is more bright because it has taken a contrast. And you can see the aorta and inferior vena cava, so they are also very bright here. But the pancreatic tissue, here it is white, but here it is black. That means it is not perfused. So any less enhancement after IV contrast means that it is ill perfused. For this another CT scan showing a lot of debris here. Indication for CT scan, diagnostic uncertainty in cases with severe disease manifestations to identify necrosis and infected necrosis, in patients with organ failure, in cases with progressive deterioration, in cases of local complications such as fluid collection, pseudocyst and abscess formation. So these are the indications, but what you do is any severe pain abdomen case where ultrasound scan is not able to give information, plain X-ray is negative, then you go with serum amylase, and if it is progressing, that means going to severe case, then you have to go for CT scan. So someone has asked me just now, can't midgut ischemia be made out on CT scan? CT scan midgut ischemia can be made out only after doing a CT angiogram of the superior mesenteric artery. There is special technique. If you do that, then you can make it out. So unless you have suspicion of midgut ischemia, you can't do that. In severe abdominal pain where a contrast enhanced CT scan is normal, then what you do is you think of doing a laparoscopy and see whether the patient condition is deteriorating. Of course, this CT severity index, this is for the undergraduate students, it is not required. Of course, postgraduates, for MS students, though not required, but if the candidate is doing better in the examination, the viva hours, they may ask you about this severity index. So how to grade the severity of pancreatitis on CT scan? That is by these parameters. ERCP, it is done in patients with gallstone pancreatitis to detect and remove the CBD stones. MRCP, it is non-invasive test and useful to detect CVD stones and pancreatic duct anatomy as well as pancreatic duct stones. Hypoechoic means that is an ultrasound nomenclature, hyper and hypo. See, in one of the classes, I will tell you about the principles of ultrasound scanning and then to read the ultrasound scan images. So then you will understand better. Because that is at least a 15 minutes talk. Laparoscopy laparoscopy or laparoscopy, if the other cause of acute abdomen cannot be excluded, then we have to do laparoscopy. If we do laparoscopy, the findings in acute pancreatitis, widespread fat necrosis, blood-stained peritoneal fluid, edematous or hemorrhagic or necrotic pancreas. So you will see fat necrosis as the soap bubbles or wax bubbles, and there will be fluid is blood stain, and you will see edematous pancreas. If hemorrhages or necrosis are there, you can make them out. The severity of acute pancreatitis, it is done by Ranson's criteria. It will take another 10 minutes. If you want to continue, I will continue. Otherwise, I will stop it here and we will take it at some other date. Because many of the students, they are saying that they have to go for prayer these days. So they asked me to stop at 6 o'clock sharp. That is why I am asking this. If they have no objection for those people who have to go for Ramjan prayers, okay, next time we will have it. Wonderful. Okay, today we will make out topic wise. So first topic will be on the general examination of the abdomen and relevance of these various symptoms, the physiological basis. Then we will talk about the gallbladder and bile ducts disease. So just I will estimate how much amount it will be there and how many hours we will have, and I will announce it tomorrow. And from Saturday onwards, we will have the paid classes. So we need some time for the technical adjustment in the website and all that. So we will do it from the. I will announce it on the tomorrow on the website, and I will send the emails to your email ID. So please check the email ID by tomorrow evening or before tomorrow evening, and also please check the website. So we'll have the details there. Basing on that, you follow the procedure, and from Saturday evening at 4 to 6 p.m., as we have suggested the time, there is preferred time by you. So we'll have those classes. So depending upon your response, even if lockdown is over, we will continue the classes. But how frequently we will continue and all that depends upon your and my convenience. Because once lockdown is over, then I will have my busy practice. You have your colleges. So whatever time that is convenient for us, whether weekly twice or weekly once or weekly 5 days, let us then discuss and decide. This okay? But what I feel is usually Saturday and Sunday, Saturday evening and Sunday morning and Sunday afternoon will be okay. That's what I feel after lockdown. So anyway, there's open for discussion and we will have it after lockdown. Any doubts, please, regarding this topic or regarding these classes? How best we can have these classes and how fruitful we can make them. So that all depends upon you and my coordination. Okay, if you have no more doubts, we'll close the session for today and meet again on Saturday at 4 p.m. Thank you once. Thank you one and all. Someone wants to talk to me. Let us see who is there. Okay, she is not there, I suppose. Usually, if you want to have the mic, you please put it in charting, because I will be focusing mostly on the chart. That's why because the symbol for the mic is somewhere. So my eye don't go to that place usually. Shilpa is there. She can talk to me or talk to all of us. She wants to have the mic. I have granted the mic. She is not responding. Okay. Anyway. Okay. Wish you all good night. Thank you. See you again on Saturday. Bye.